Hello and welcome to another ultrasound case of the month. My name is Tristan Withers and today we're going to be talking you through an emergency medicine case where ultrasound was used, and I'm going to talk you through the pictures and how to interpret them. This is our second case, and we have an 85-year-old man who presents after having a AAA repair several years ago and also having had some kind of non-sustained episodes of ventricular tachycardia that have been investigated by the cardiologists, but he was deemed not a suitable candidate for a pacemaker or other device because of his frailty. So he is called in as an ambulance pre-alert, and he's got abdominal pain radiating to the back. He has very low oxygen saturations of 70%, and he's hypotensive at 80 on 49. So at this point, as you can imagine, we're starting to get a little bit antsy. We are preparing a resus bed, we assemble a full team, and we're starting to make preparations for transfer to operating theatre if that's necessary. But actually, it turns out when he arrives, he's actually looking pretty good. He's no longer hypotensive, he's saturating well even though he's on a lot of oxygen. He's conscious, he's a little bit confused, but otherwise he's pretty alert. And he does have this large left-sided abdominal mass. He has an ECG which actually captures a short run of non-sustained ventricular tachycardia, and you can see these broad complexes in the middle of the trace, which is the ventricular tachycardia, and then there's a few narrow complexes on either side that are a different rhythm from the heart. So he's doing something slightly unusual with the electrical activity of his heart, but he otherwise looks pretty well. So one of the first things we do is abdominal scan of his aorta to have a look to see what his aneurysm is doing. And just to orientate you, this is using the curvilinear probe or the abdominal probe. It's the same one we use for fast scans. The probe is in the lateral position, so the marker's on the right of the patient and on this side of the screen. So this side of the picture is the right of the patient, and this side of the picture is the left of the patient. This is where the skin and the subcutaneous tissues are, and then as we go further down the screen we get deeper and further away from the probe. So we're going to start by basically putting the probe pretty much up underneath the xiphisternum in the transverse plane, and then we're going to see when we can catch a glimpse of the aorta, and I'll just play you this clip now. So as we move the probe further down and start to look more inferiorly, we start to get some images coming into view. Now I'll pause this here. So what we can see in the middle are a few things that I'll just try and orientate you with. So the first thing to look at is at the bottom of the picture we can see the vertebrae, and we can see the bright white shadow from the front of the vertebrae, and then the dark black shadow at the very back, because the bone basically doesn't let much sound waves through, and so everything behind the bone looks black. Now, usually the first structure in front of the spine is the aorta, and there is something here which looks like a kind of walled vessel. You can see a bright white circle there with some black stuff in the middle, and that at first glance might look like his aorta, but it's actually not. So the aorta is actually this much larger circle that you can not even fully see on the screen. But here's the posterior wall of the aorta. The anterior wall is over here, and the lateral wall is going way off to one side, several centimeters off to the left. And this is an enormous abdominal aortic aneurysm, and you can see some heterogeneous material on the inside of the aorta, which is blood clot, or presumed to be blood clot. And then within the lumen of what actually is the repaired aorta, we can see some black fluid density stuff, which is presumably uncoagulated blood. And you can see a little bit of pulsation within that graft there. So this is just a still showing that same picture. And I've labelled here just to emphasise the point that this middle circle is actually the graft, and this larger circle on the outside is the aorta. And if I measure it here for you, you can see that it's about 11 or 12 centimetres, and this is proximally, so that's really big. Aneurysmal is anything bigger than 3 centimetres. So the next thing we did was a fast scan to look for free fluid in the abdomen, and there actually wasn't any. The next kind of few hours were a little bit uncertain, because we found that the patient's blood pressure would keep going up and down. and he would suddenly start to become hypoxic and look really unwell and pale, and then he seemed to just suddenly get better. And it actually turned out that these were coinciding with runs of VT that he was having in his bed, so it was actually nothing to do with his aorta. He was getting these brief runs of VT where his SATs and his blood pressure would suddenly drop because of poor perfusion, and then his heart would go back to its normal rhythm, and everything would look better again. So the next thing we did was an echo, and this is a parasternal long axis view. So echoes are a little bit hard to explain if you've never seen them before, but basically what we've done is we've put the probe, and we're using the phased array probe, which is the little square one some people call the cardiac probe, and at the moment we've got it in the roughly the second intercostal space just to the patient's left of the sternum, and we have the marker pointing up towards the patient's shoulder, which is confusingly on the other side with the cardiac probe, so it's on this side of the screen. So the apex of the heart is up towards the top left of the image, and the left ventricle will be on this side, and then we'll also have the left atrium down to the bottom right, and between those two we'll have the mitral valve between the left atrium and the left ventricle. Then we'll have the aortic valve coming into the aortic root and the ascending aorta, and the right ventricle kind of wraps around the front of the left ventricle. And the other thing to notice is we've got the posterior pericardium very clearly visible as a bright white line here, and another bright white line at the top. And if we saw two bright white lines with a black space in between, that would make us think there was a pericardial effusion. The descending aorta is a little circle that usually appears around here. So the first thing to say is that we kind of have to have a systematic way of looking at these echoes. So is there a pericardial effusion? No. Is the left ventricle beating well? So we don't necessarily have to comment on an exact ejection fraction in the emergency department, but we do want to get an idea of the overall function. And one of the things we're looking at is how well this wall and this wall of the left ventricle are contracting to each other. And it doesn't look like they're contracting very much at all. The other thing is we want to see a 1-to-1-to-1 ratio of this left atrium, the aortic root, and the right ventricle, and we can see that the left atrium looks a bit bigger than the other two, so that suggests some left atrial enlargement. So this is the short axis view. So what we've done is we've turned the probe 90 degrees from where we were at before. In the same position, we've just rotated it clockwise 90 degrees, so the now marker is pointing at the left shoulder of the patient. So what we're doing is taking a slice through the left ventricle in cross section. These two bright white dots here are the papillary muscle, so we're about midway down the chamber. You normally want to get this as circular as possible, but he actually had a slightly oval shaped heart at different points of contraction, and that's just because not all of the wall is contracting together. So what we want to see when we play this loop is that the muscle of the left ventricle contracts towards a point in the middle symmetrically, and actually this bit is contracting, which is the septal wall, and the rest of it doesn't seem to be contracting well at all. It just seems to be kind of floating around, not doing very much. So this is an apical 4 chamber, so we've now moved the probe round to the apex of the heart, so we're kind of round on towards the left side of the chest and lower down than we were before, maybe the 5th or 6th intercostal space. And we're looking up through the heart, so the probe is at the apex, so the apex of the heart is here. We've got the left ventricle and the right ventricle, we have the left atrium and the right atrium, and then we can see the septum going here, and then we've got the mitral and tricuspid valves between the atria and ventricles. And again, you can kind of see, looking at this left ventricle, that this top bit is contracting, that's near the apex and the right ventricle, and almost the entire rest of the wall is not really doing anything. And then finally we take a look at his IVC. We do also usually look at the heart in the subcostal view, and I didn't get particularly good pictures for this, so I'm not going to talk you through them. This is just to say that the IVC looks like it's showing pretty normal respiratory variation as he breathes in. So the IVC in theory represents filling, or it can represent pulmonary artery pressures, because you get high pressure in the lungs, you get high pressure in the pulmonary artery, which goes all the way through the right ventricle to the right atrium and finally back up to the IVC in a kind of a column of fluid, if you like. in practice, it's only really helpful if the IVC is either very large, meaning greater than 2 centimeters, and not collapsing, which suggests overfilling, or slit-like or narrow, which is less than 1 centimeter and collapsing a lot. So even though this IVC looks quite wide, it is still collapsing appropriately, which is somewhere in the middle, so it doesn't tell you that much about his filling status. Finally, the patient went for a CT abdomen, which you can see here shows a graft in the middle of his aorta and then a very large aneurysm. And if we look a little bit lower down, so this is now below the level of the kidneys, we can see the graft is bifurcated and we have this still enormous aortic aneurysm. But actually didn't show that the aneurysm was perforated or leaking or ruptured. And it looked pretty similar to when he'd had a scan about 3 years prior to this. So we ended up observing this guy overnight. He was managed conservatively. He was discussed with the vascular surgeons and with the cardiologists again, and they didn't feel like aggressive intervention would be in this patient's interest because they thought the risks of any procedure would be quite substantial. So in the end, he ended up being discharged home. He was looking quite well at the time of discharge, and all our earlier panic about this man coming in with a likely ruptured aortic aneurysm turned out not to be realised, which was a pleasing thing for me on my night shift. So that's the end of the case. I hope you've enjoyed listening and watching and looking through some of the pictures. I hope this has helped you understand what sort of things to look at when you do an aortic scan or when you do a basic echo in the emergency department. Thank you very much.